So I would like to begin by first saying thank you very much to the people at MECA for inviting me and giving me the opportunity to speak to you about information that is captured from the EAdi signal. And the EAdi signal stands for Electrical Activity of the Diaphragm. And as Christer told you in his previous presentation, this is a signal that we pick up with electrodes on a conventional nasogastric feeding tube. And the signals that we're picking up essentially reflect the neural respiratory output. Okay, so I'd like to share with you today my experiences in both babies and adults who are both on mechanical ventilation and off the ventilator. But most importantly, I would like you to go home, and next time you're standing at the bedside, I would like you to ask yourself, what is the electrical activity of the diaphragm in this patient? Because I think you'll get addicted now to the signals when I show them to you. So we'll begin. Christer mainly talked to you about the methodology of measuring diaphragm activity in adults, and my work is primarily involved in measuring the control of breathing in pediatric patients and in preterm neonates. And essentially the methodology is the same, except everything is smaller. The interesting thing about the preterm babies is that even if they've come off the ventilator, they often have problems with feeding for weeks, and they stay in the neonatal intensive care unit, and they are monitored for their apnea of prematurity. So even if they're not receiving any ventilatory support, you can still monitor their control of breathing until while they have this feeding tube down. Here is a photograph of the prototype catheter we're using in the babies in our unit. It is 5.6 French in size, and you can see that, if I can find the arrow, that the interelectrode distance compared to the adults is much smaller. We're using about 5 millimeter or 6 millimeter interelectrode distance. And so for babies that are 1,200 grams or less, we use catheters this size in our unit. And I think the policy about French size varies between units, but these are the ones we're using. And again, just to re-emphasize, I've put this slide here to show you and to remind myself that you don't need an X-ray to confirm the position of the catheter. What we do is we do our external measurements as any feeding tube placement would be, and then we put it down. And what we do then is the fine-tuning of the electrode positioning based on the ECG signal. And you can see here below the X-ray, so this is an X-ray taken from a 28-weeker that we studied the diaphragm activity. And you can see in the bottom here, there are tracings from each of the electrode pairs. This is at the top of the electrode array, channel number 8, we call it. This is at the bottom of the electrode array, and you can see the ECG signals here, here, and here. And what we do is we look at the P wave, and when the P wave is strong at the top of the electrode array and not present at the bottom of the array, you are very likely to be in the correct position to capture the diaphragm signal. And this is the diaphragm signal here, this what we call the blur of black cloud or noisy signal. And here's another breath. And we've actually been able to use this method of ECG guided positioning in rats and in rabbits and in adults and in the babies. So we're quite confident that this is a useful method. So how do we take this signal here, these 8 electrode signals, and translate this into something that we can interpret? So what I'd like to do is to show you how, Christer showed you all the different steps in the analysis, how we convert these 8 signals into a waveform. And what you see here on the bottom panel now is the diaphragm electrical activity waveform that we have processed. And I'm just going to trace it over with my finger here. It's this pink line here. And from this waveform, which is just like a pressure waveform or a flow waveform, we can interpret certain things. So for example, you can look at the amplitude of the signal, so what we call the phasic electrical activity of the diaphragm. And this phasic activity represents a progressive increase in inspiratory effort made by the patient. When the signal starts to go down, it means that the brain has told the diaphragm to stop making an inspiratory effort. Also, usually the signal goes back down to 0, for example, in most adults. And the tracings Christer showed, for example, this morning, that the signal increases, it decreases, and then there's a pause between breaths when the signal returns to baseline. But often what we're finding now in the babies and in the lung injury models we have is there's actually the presence of diaphragm activity during expiration, and we call this the tonic activity of the diaphragm. This waveform can be compared to pressure and flow waveforms, and it gives you an indication about patient-ventilator interaction. And as well, I'll show you a few examples today where the signal is not present and how this in itself can also give you useful information. So I'm going to talk to you about phasic diaphragm activity, tonic diaphragm activity, the interaction of the waveform with, or the comparison of the waveform with other waveforms, and when you don't see a signal, what this can mean. This is a slide. The graph is taken from a paper, my very first study, looking at diaphragm electrical activity in mechanically ventilated patients. It represents the data from one patient, and what you have on the left panels are the diaphragm electrical activity, and on the right, it's the transdiaphragmatic pressure, and it is for an average breath of 1 minute of data. And all I wanted to show you with this slide is that as you increase the pressure support, so the solid black line is when there's no assist, so you have a very high diaphragm electrical activity, which means you have a very high respiratory drive. The transdiaphragmatic pressure, which is an indication about the force that the diaphragm is generating, is also very high. And as you increase pressure support systematically, you get a progressive reduction in the diaphragm electrical activity and the transdiaphragmatic pressure. So as you unload the diaphragm, you also reduce the respiratory drive. Okay, now this is not always the case with increasing pressure support. We recently submitted a paper to pediatric research where we showed that sometimes, and I'll point you to these pink boxes, on the bottom left, you have the transdiaphragmatic pressure time product, which is the transdiaphragmatic pressure per minute. And on the right, in the pink box, you have the electrical time product, which is the amount of diaphragm electrical activity per minute. And it's for pressure support ventilation, and the data is obtained in a rabbit with an acute lung injury. And what we found was when we went from a low pressure support to a medium pressure support, we saw, like we did in the previous study, there was a reduction in both the force generated by the diaphragm and the diaphragm electrical activity. But when we went to a very high level of pressure support, we actually saw an increased transdiaphragmatic pressure and an increased diaphragm electrical activity. And what we found was that in this animal model, when you increase the pressure support, there was a progressive increase in the delay between the onset of the diaphragm activity and when the ventilator triggered. So there was increased work just to trigger the ventilator. But we also saw that there was a progressive increase in the number of wasted inspiratory efforts. So at a very high level of pressure support, even though the diaphragm activity was really trying to trigger, the rabbit wasn't getting an assist. So in effect, due to the worsened asynchrony, there was an increased work done by the diaphragm. So just because you increase pressure support does not necessarily mean that you are unloading the diaphragm. Okay, now we're going to do a few of these, what we call the quizzes. This is data taken from an adult patient who is breathing on pressure support ventilation, and you have the flow tracing on the top, the volume in the middle, and the ventilator delivered pressure on the bottom. So it looks like the patient is triggering. It also looks like there's a few wasted inspiratory efforts. You can see that by these blips here. So I'm going to ask you now, how many of you think that this patient is breathing? Remember, this is a triggered mode of ventilation. 10 hands. How many of you think this patient is not breathing? This is a different patient than the one Krista showed before. That patient was on volume control. So one person thinks the patient's not breathing. So this is what the diaphragm electrical activity looks like in this patient. So this patient is not using the diaphragm during this period of mechanical ventilation. And I have to emphasize again, these are ventilator settings that are set by a respiratory therapist or a clinician in our unit, and it's not us who have set this. What we've done is we've just gone in and monitored the diaphragm activity. So do you think that this patient has a diaphragm paralysis? Or perhaps that we have sedated them, maybe other muscles are triggering the ventilator? Well, when we switch this patient to NAVA, again, this is a different patient from the one that Krista showed this morning. You see that when the diaphragm activity is required to control the ventilator, the patient uses the diaphragm activity. So it's not that the patient couldn't, it's just that they didn't. And also want to let you know that we were able to successfully ventilate this patient on NAVA for a 24-hour period. So when you see this increase in diaphragm activity, it's not something that they can't sustain. I'm going to show you another example now. This is data taken from an adult COPD patient breathing on pressure support. It's from our colleague in Montreal who's doing a study comparing pressure support to NAVA. On the upper tracing, you have the flow signal, and the second, just below it, is the airway pressure. So I think you can all agree now from also the tracings that Bob Kashmerick showed us that these little blips here indicate that perhaps the patient is making an effort to trigger, but the ventilator didn't sense that. So are these wasted efforts? And how should we deal with it? Maybe we should make the trigger more sensitive. Well, actually, when we look at what the patient is really doing, here you have the third tracing from the top is the esophageal pressure, and the fourth tracing from the top is the diaphragm electrical activity. And what you can see clearly is that the assist level was set way too high in this patient, and I'll try to find it there. You actually have a positive deflection in esophageal pressure throughout the assist period. But what you can also see is that the patient, here's the evidence of the wasted effort. It's very, very low respiratory drive in this patient. You can see here that the patient is actually just doing a tiny, tiny little bit of a respiratory effort to trigger the ventilator, and then there's no activity of the diaphragm at all. So the patient is just doing minimal amount of diaphragm activity and taking a ride for the rest of the breath. Now, when we lowered the assist in this patient, this is what we saw. We saw an immediate increase in the respiratory rate to 30. But we also saw that just by lowering the assist by 7 centimeters of water, at least in this patient, that we were able to get the respiratory drive to come up just a little bit and just enough to successfully trigger each breath. So the point I wanted to make with this slide is that sometimes in pressure support, you can over-assist to the point where you reduce the drive so much that they fail to trigger. Here we have another example of an adult with a respiratory failure, breathing on pressure support. I believe there's also renal failure. And you have, again, top panel is the flow, below it is the volume, then the ventilator delivered pressure, and we've put the cursors to indicate when the flow is starting and cycling off. And again, I'm going to ask you, is this patient breathing or not? Who thinks the patient is breathing? Two people. Who thinks the patient is not breathing? Oh. Well, this patient's breathing a lot. So you see, we have a lot to learn from the diaphragm electrical activity. This patient is all over the place. You have examples of where there's a wasted inspiratory effort. So you have presence of an inspiratory effort. The brain tells the diaphragm, I want to breathe in, but the ventilator does not trigger, despite the fact that the respiratory drive is quite high. You have examples where there's a delay. So here the diaphragm electrical activity starts. This is when the ventilator kicks in. The ventilator continues here, and the patient makes another effort. So you have very severe patient-ventilator asynchrony in this case. And this is where I think the limitation of today's technology is. I mean, we didn't sit there and try to optimize or anything like that, but this patient has a very, very strong respiratory drive and not able to trigger. So that's the grown-up data. Does asynchrony occur in infants? This is data that we obtained in Montreal a few years ago. On the top panel, you have the diaphragm electrical activity. On the bottom, you have the airway pressure. This data is taken from a 9.5-month-old baby who has an aspiration pneumonia, and the mode is an SIMV plus pressure support. And you can see here examples of patient ventilator asynchrony in this kid. First, you have the delays, like I showed you in the adult, where the diaphragm electrical activity starts here at this line, and this is where the ventilator kicks in. During the delivery of the mandatory breath, the baby actually makes another inspiratory effort. And then another example of asynchrony, which is the worst case, which is when the brain wants to take a breath and fails to trigger the ventilator. So just in this 5-second period, you have 3 examples of patient ventilator asynchrony. And I didn't just take my best example. This was going on and on and on in this baby. This is the group mean data from that study we did. So what we did was we looked only for the mandatory breaths, which are supposed to be triggered with a flow trigger. And it's the group mean data comparing the neural timing, which is the bars at the top, with the ventilator timing, which is the middle bars. And you can see here when you compare the neural timing to the ventilator timing that there is a trigger delay, which we found was about 110 milliseconds. And you might say, that's not so long. But when you consider that the neural TI in a baby is about 300 milliseconds, that means 30% of their neural inspiration is spent trying to trigger the ventilator. You also have the prolonged delivery of assist into neural expiration, and Rolf showed us earlier that this can have a significant impact on the breathing pattern. And you can see here that it's about 50% of neural expiration. I must say that this is an SIMV mode, so that means that the ventilator TI is time cycled. And in this unit where I was working, they were setting the TI to 700 milliseconds. So just by monitoring the diaphragm electrical activity, we were able to show them that this was too long. So I thought that that was very interesting. And when you compare the entire breathing cycle here, you can see that 53% of the breathing cycle is asynchronous and 47% is synchronous. And this is for a group of 12 babies on SIMV. So I would like to just caution you, when you see a mode of ventilation that's called synchronized intermittent mandatory ventilation, that the synchronized part may not be valid. Okay? I don't know why they modes can be called synchronized when they haven't evaluated the synchrony. So it's kind of a paradox. Okay, now let's look at babies who are breathing without a ventilator. As I mentioned to you before, most adult signals, the waveform increases during inspiration, decreases during expiration. There's usually a pause in between where the signal returns to baseline. This is data obtained from a study we just finished at, in the NICU at Women's College Hospital. And I was amazed by the chaotic breathing pattern we observed. Here you have just the diaphragm electrical activity on day 1, on the top left, day 1 in the evening, and day 2 and day 3. So 4 examples of diaphragm electrical activity in the same baby. And this baby's breathing on room air, it's not on a ventilator. And I just wanted to point out to you the variability in the signal. So you have phasic breathing, where the signal goes up and down, which is variable from day to day. But you also see that this background diaphragm activity, the signal doesn't go back down to baseline or to 0. The background diaphragm activity is actually also very variable. So you can see here, there's a very large amount of tonic activity compared to, let's say, over here. You'll also notice the presence of sighs, where the babies take very deep inspirations. And then you also have these periods of apnea that can vary in length anywhere from 2 to 3 seconds up to 20 seconds. So the point I wanted to make with this slide was first to show you that it's a very variable breathing pattern, but also to introduce this concept of tonic activity to you, because I think it's something that no one really thought about before. Then when we started to look at our day-by-day recordings in the adults, we also saw, they also have very variable breathing patterns. So this is just to show you a slide of diaphragm electrical activity taken in an adult patient with an acute lung injury over a 6-day period. So we ran a trial of NAVA the day before, and then over the 6 following days, we recorded the diaphragm electrical activity. And the airway pressures, the ventilator settings that you see are set by the respiratory therapist. So we just went in and monitored. So you can see here the variability in the breathing pattern and how it's completely unrelated to the level of the assist that was set by the RT. So I think we also have a lot to learn in the adults as well. We did a study trying to evaluate or to understand a little bit more about this tonic activity. And we believe that the tonic activity is actually a mechanism by which the baby or the animal or the patient is trying to keep the lung open. So rather than expiring completely to FRC, the diaphragm remains active and it kind of prevents de-recruitment. It's kind of like a self-generated intrinsic PEEP that the baby is doing. So in this study, in intubated babies, you have the diaphragm electrical activity here, you have the airway pressure here, and what we did was we removed the PEEP and we set it to 0 very briefly, which we did here, and what you see is an instantaneous increase in the tonic diaphragm activity that I've indicated with the black line. And then when we put the PEEP back on, this tonic activity disappeared. So it does support our hypothesis that the tonic activation is trying to keep the lung open, because when we give PEEP and keep the lung open, the baby can actually rest and not try to keep the diaphragm so active during expiration. We did a study in rabbits, and the first author is Jean-Christophe Allot, who was doing a fellowship with us for a year, and actually he was able to show that you can actually use the tonic activity of the diaphragm to titrate the PEEP. So you see here, this is a rabbit with an acute lung injury. This is the diaphragm electrical activity. You don't need to really focus on the bottom panel. And right after the injury, what we saw when the PEEP was 0, this is an intubated rabbit, that there was a very, very high level of tonic activity with very non-discernible phasic breathing. When we gave the animal a PEEP of 5, we saw, again, this is all instantaneous recordings. They're all, it's a time tracing. When we gave a PEEP of 5, the tonic activity was immediately reduced, and we started to see restoration of the phasic breathing pattern. Again, when we increased the PEEP up to 10, we restored the phasic breathing, and the tonic was reduced further. So just by increasing the PEEP, we're able to allow the animal not to concentrate on the tonic activation, but now the animal could focus more on the phasic breathing. When we increased the PEEP even further and up to between 15 and 18, we actually saw an apnea in these rabbits. So this was very interesting, and it's kind of a new way of looking at the diaphragm activity, not just from the phasic point of view, but as well from the tonic point of view. Now, babies and rabbits are very vagal, and these are vagally mediated reflexes. So we were wondering, does tonic activity occur in adults who are believed to have less strong vagal reflexes? And this is a graph I took from a study by Meeson, where in healthy subjects, they measured the diaphragm activity and the electrical activity of the intercostal muscles. And what they did was they applied negative pressure at the airway. And you can see here on the left panel that when they applied negative pressure at the airway, that they saw a slight increase in the tonic background activity of the intercostal muscles. And then later on in the paper, they plot that as you decrease the FRC progressively, there's a progressive systematic increase in both the diaphragm and the intercostal muscle tonic activity. So there is some evidence that in healthy adults, at least, that this reflex is present. We have observed, I think in 1 or 2 patients with ARDS, that when you reduce the PEEP, there is a slight increase in the tonic activity of the diaphragm. But it's not something we see all the time. It's not as systematic as we see in the rabbits or in the babies. This is an interesting graph. It shows a rabbit with an acute lung injury breathing on the volume control mode. The top panel is the diaphragm electrical activity, and on the bottom panel is the volume. And what we've done is we have put gray bars over the assist period, so when the ventilator is delivering the assist. And I think that you'll see that something looks completely backwards here. Okay, so what you see is that as the ventilator delivers tidal volume, there is actually a reduction in the diaphragm activity. During expiration, the animal is permitted to breathe in or to increase the tonic activity. We don't know what kind of activity it is. But again, when the ventilator delivers the assist, this causes an immediate cessation in the diaphragm activity. So you have a 180-degree out of sync situation here. And I think we've seen this, Christopher, if I'm not mistaken, in at least one of the patients that we've studied, the adult patients. This is the last example I'm going to show you, and it tells you about the diaphragm electrical activity in a preterm baby who had a bradycardic spell. So I'm sitting at the bedside and I'm monitoring for hours and hours, and I'm looking at the diaphragm activity. On the top panels, I wrote ECG, because you know we have the ECG signal on our catheter, so we can plot it as well. So each black bar is a heart rate, is a heartbeat. And you can see here the typical chaotic breathing pattern I showed you before. Heart rate's about 150, baby's saturating well. And then about a few minutes later, you can see here that the diaphragm is completely silent during this period here. And what you also see during the apnea is that the heart rate starts to go down. And in fact, the heart rate went down to 66 in this baby. Saturation fell to 82, and I called the nurse over because this was the first time I'd seen this. The alarms were going off. The nurse came and gently aroused the baby, who immediately did a huge inspiratory effort and then breathed phasically on top of a lot of tonic activation. Sorry, I lost my mouse. And then again, when the nurse walked away, the baby fell into an apnea, but this time the baby aroused himself. Again, big inspiratory effort, maintaining the tonic activity. And when you look 3 minutes later, it looks just like it did 3 minutes before, just this chaotic phasic and tonic. So I think we can learn a lot about the apnea of prematurity in these babies. They don't even have to be on a mechanical ventilator, but we can learn a lot about they do a lot of caffeine treatment to reduce the apnea of prematurity, and we can evaluate all sorts of therapies from that point of view. So in summary, what information do we capture from the EADI signal? Well, the phasic diaphragm activity can provide information about changes in respiratory drive. The timing of the diaphragm activity in relation to another waveform during mechanical ventilation can provide information about patient-ventilator interaction. The tonic diaphragm activity can provide information about the diaphragm's role in maintaining FRC. And by monitoring the EADI, especially in the small kids, can provide insights into the mechanisms of apnea of prematurity. And thanks for your attention. And I just wanted to say one more thing, that Krister's interest in waveforms goes way back, and I'm not allowed to say how far back, but this here is Krister thinking about waves.
Thanks very much, Jennifer. Great talk. Questions from the audience? Let me ask you, Jennifer, it looks like, I guess the message you're giving is that just measuring electrical activity is a useful in and of itself. Forget NAVA, that you can learn a lot with any mode of ventilation or on spontaneously breathing subjects as well. I think that's an interesting message. By the way, microphone up here. It was quite interesting, and I know about some of the data, but the tonic activity at expiration, because you think yesterday there was a lot of talk about individually setting ventilation parameters for each particular patient. And theoretically, this could say, if again, the issue of are you getting appropriate feedback from the lung, but if that is, maybe that's the way we set PEEP. You know, the patient says, they integrate all the afferent information from all the lung units, says, this is where I want my PEEP. You set the PEEP there. So, I mean, clearly it has to be tested out, and I don't think there's enough data in humans, but pretty interesting.
Yeah, like I've said, we don't see this strong change in tonic activity with the PEEP in the adult patients. In the babies, we were able to do these very rapid reductions in PEEP down to 0 for a 30-second period. We had ethics approval to do that. But I believe in the adults, we're doing a very slow titration. So we need to learn a lot more about the adults, I think.
Absolutely.
Yeah.
Question at the front?
Yeah, thank you very much for a fascinating presentation. Can you relate these phenomena, like this tonic electrical activity, to Herring-Brouwer reflex? I mean, are we actually looking at this particular Herring-Brouwer reflex and the phenomena here?
It is a reflex. It's the Herring-Brouwer deflation reflex. So there are receptors that sense when the FRC is too low, feeds back to the respiratory center, says, open me up. It is a Herring-Brouwer reflex. If you do a vagotomy, you don't see tonic activity in the rabbits.
So actually, we now have a clinically feasible method to have our hands on the third stimulus for respiration or ventilatory drive.
Jennifer, one of the back, while you're getting at one of the slides you showed earlier said you asked whether the patient was breathing. It looked like the patient was, and yet when you unmasked, there wasn't. Do you think that was other inspiratory muscles that were triggering?
Yeah, it could be.
Yeah.
I don't know what it was or if there was any auto-cycling but you know, the ventilator says trigger, trigger, trigger. I think we can all agree that when you have a silent diaphragm and for many hours or many days, that this isn't good for the muscle. You want the patient to use their diaphragm.
Bob?
Yeah, I mean, basically that was a question I was going to ask about that one slide. I mean, pressure support had to be triggered,
exactly,
you know, by the patient. And if the diaphragm activity is gone, I mean, some other muscle had to be, you know, activating it. How do you know how much diaphragm activity is the right amount? As we ventilate patients, I mean, we intubate somebody with COPD. You showed that one example with those very low level of diaphragmatic activity. Some breaths miss, but I'd consider that pretty good. That diaphragm probably isn't doing a lot. This patient, you know, is stressed. Maybe the diaphragm is fatigued. Is that a good thing for 24 or 48 hours? I mean, we clinically try to rest patients for that period of time. I mean, is that what we should be seeing? Or what is the level that is a good level as opposed to a bad level of diaphragmatic activity?
First of all, I can't tell you if you have 10 units of EMG, if this means good or bad or high or low. I can tell you that we can see the changes, and that's why I said in my summary slide, by monitoring the amplitude, you can see the changes in the respiratory drive. I think clearly you don't want to have very little activity, and you don't want to have too much activity. You always want to have the middle in between. Again, we don't have a number that we can say this is good or bad. We are doing some studies now where we're looking for 12-hour periods on controlled mechanical ventilation versus NAVA for 12 hours and looking at the effect on the muscle from contractility point of view. But there is some evidence in the literature that disuse of the muscle weakens it. And I don't remember the days or how long those studies were.
I mean, no question. Kathy Sassoon has got some data, but she compares it to controlled ventilation with no activity to the activity necessary to trigger the breath. But you're telling me triggering the breath could be low-grade activity or it could be excessive activity. So, I mean, it's difficult to reconcile, you know, that data. And, I mean, it would be nice, and I'm sure as time goes on, you will be able to give us an idea of what is the best level of diaphragmatic activity to actually see in a given patient.
I don't know if Christer wants to make a comment or not on this.
I'm sure he does.
I'm sure he does.
Can you bring one here? Presumably, can you bring a microphone to the front? Presumably, this is early days, so the measurements have been made in a few patients by a couple of investigators. You know, once this gets more, if it gets more widely used, I think we'll learn a lot more.
I think that what you're saying, Bob, is really the key issue. I mean, how much should you rest the patient in an acute phase? But if you take some of these guys here, they have been more than 12 months on the ventilator. You can't get them off. There is an issue there. But number two is, the thing is, you trigger the ventilator, and that's very easy. And that's especially COPD. If they get triggered, they stop. As soon as the pressure support starts, they stop. They just take a ride. They love it. And the thing with this is that it's the off-cycling that's the problem. When you have a system with a long time constant, the ventilator can just go on forever. It never stops. And this is very comfortable for a patient. Like as Jennifer showed, there's like this patient in one graph that is actually on controlled mode ventilation using pressure support. Just making an effort that is minute on a flow trigger, very efficient, starts the ventilator, gets over assist, gets hyperventilated, doesn't have to do anything. And I think this is what the problem is, that the ventilator doesn't stop when the efforts stop. And I agree with you that how much effort they should do, that's one thing. But the effort should at least last the length of the breath. That is, I think, the biggest problem today. There's a kickstart, and you can use like a little jump of your chest wall, and that's it. You don't even have to use your diaphragm. I think that's where the gain is of this, is that you can really see that you have severe asynchrony.
Question, third row.
This is just absolutely fascinating. My mind's going 100 miles an hour here with all the implications here. But just some comments as I'm seeing this. In babies, I'm seeing babies that are tachypnic and maybe not working so hard, but we finally have a way to control them and maybe meet their respiratory drive. And I'm seeing implications with neuromuscular patients, helping them out and meeting their needs. And I think it takes some of the question of the equation out of setting eye times. That was some of the discussion yesterday, and setting the PEEPs and really meeting the demands of the patients. So I'm just fascinated by all the implications here. I think preemies gaining weight faster because worker breathing will be less, potentially decreased IVHs, and air leaks. I think it's just really limitless in terms of where we can go with this. Thank you.
Certainly pretty exciting. It'd be nice to get more outcome data. You know, I mean, theoretically, this looks great. We'd love to see more outcome data. Yeah, question up at the front on the left.
Could you comment on the change in electrical activity with the caffeine therapy? And have you observed any changes with any type of obstructive apnea or resistive loading of these patients?
Could you repeat your question, please?
Any changes in electrical activity with caffeine?
With caffeine. The baby I showed you that had the apnea with the bradycardia was on caffeine. All the babies I studied were, and I observed it in all of them, this event, sometimes 4 times in 1 hour. So I think we need to reevaluate the whole caffeine apnea issue.
How about obstructive apnea?
We didn't measure the flow in these babies, so I can't tell you whether they were obstructive or not. But you can imagine that if they have an obstruction with an inspiratory effort that you can measure, it would be high because they're occluded. So when they make their inspiratory effort against an occlusion, if it's obstructive apnea, the drive would be high. So you can tell the difference between an obstructive or central apnea with this signal.
Jennifer, do you have data before and after caffeine?
No, I don't.
The other issue was with babies with a 2.5 millimeter ET tube. The resistive load is quite significant. And there's some work done by Olinsky which basically showed that the respiratory output could be quantitated to the occlusion pressure. But it would be nice to see the signal variation on this and the electrical changes.
Sure, I'll show you later this afternoon. I'm going to show you some data on non-invasive ventilation where we have the rabbits on NAVA before and after extubation, and you can see the effect of extubating on their diaphragm activity.
Thank you.
Okay.
Question over here. Can we have a microphone? In the center, third row.
Have you seen any characteristic kind of waveform patterns or a diaphragmatic electrical activity in your animals or other subjects reflecting fatigue? Or it just seems like you have some chaos, but I'm trying to make sense of what would I see in a patient that may be transitioning into perhaps or weaning that patient or preparing to liberate that patient. I'm trying to see if there's a transition and characteristic transition in the electrical activity of the diaphragm and how that could help give me a signal as to whether I have too much inspiratory or diaphragmatic loading as compared to, trying to walk that balance. Could you comment on that?
So we could spend all day on that topic. But first of all, there's 2 ways of looking at the signal. Like Christer said this morning, in the past, we were very interested in respiratory muscle fatigue during weaning, and that's actually where our research originated. So if you transform the signal into the frequency domain, you can see you can see from power spectral analysis very rapid changes in the signal as the muscle, the excitability of the muscle for the electrical activity to propagate along the muscle is slowing. And that happens long before the force output of the muscle starts to go down, what we call the contractile fatigue. So yes, there is possibility of information in the frequency domain from the signal. And again, as Christer mentioned this morning, the impact of a slowing of the conduction velocity of this signal is actually an increase in the power of the signal. So because it gets slower, in essence, it gets a little bit bigger. So yes, the waveform would get larger just from that phenomenon. On the other hand, if you start to have contractile fatigue and your muscle becomes weaker, to maintain the same ventilation, you would have to increase your respiratory drive. Correct? So if you have a weakened muscle, to get the same mechanical output, you have to increase your drive. So perhaps as you're weaning, if contractile fatigue exists during weaning, I don't know, but you would see an increase in the diaphragm electrical activity.
The salient differences are phrenic nerve involvement and phrenic nerve output to the motor end plate versus the muscle itself and how the muscle responds to depolarization and activation. So I'm interested to see, I would assume that in our patients that are borderline fatigue, you would see a change at the phrenic nerve level from maybe a 60, 70 hertz kind of activation pattern to a much higher frequency output. And I'm trying to, reconcile those two. But it's interesting to see. I definitely would expect much higher output to a weakened muscle, and I would expect it to be on the 120 hertz phrenic nerve depolarization level.
We have a paper on the relationship between the amplitude of the signal, the motor unit recruitment, and the firing rate. And if you want after, I can talk to you about that.
Very good, thank you.
Okay.
Do you have any data? We have the microphone at the back on the fifth row. Any data, Jennifer or Christer, on during measuring EA activity during a spontaneous breathing trial? You know, you've got a patient, you want to wean them, so you take them off the ventilator just to see how they do and how that correlates. I think that would be quite interesting. Any data yet?
Well,
You're gonna show that?
No, we need data.
Okay, nothing yet. There's someone, yes.
Yes, do you have any interesting observations regarding hiccups?
It's the famous question. I've recorded in the babies like hiccups, and what they are is they're very, very brief, large signals. So what a hiccup is, it's a mass action potential to the diaphragm, right? So all the motor units are depolarizing at the same time. So from a monitoring point of view, that's what you see. If you're using the diaphragm activity to control the ventilator, what do you think would happen in pressure support ventilation, for example? The hiccup would trigger the ventilator, and the ventilator would continue to give that pressure support breath until the flow declines. But with NAVA, because the neural activity is both cycling on and off the ventilator, that the delivery of the assist will be very brief. So it'll just trigger on and cycle off. It'll be like a puff.
One question, second row.
Thank you for a very, very interesting talk. One comment that you made about SIMV and whether that term should be used for a non-synchronized breath. Historically, and I think the only other person in the room old enough to help me with this would be Bob. Yes, Mary. SIMV, as I recall, was created primarily to talk about patient starting to breath, patient triggering, as we know the term today. But I think in today's world of patient synchrony, where we're really looking at what starts the breath, how the breath is applied in comparison to what the patient wants, as well as ending it, you have a very good point. And maybe synchronize isn't a good word for something that only talks about one little phase, the beginning of the breath.
Yeah, I was being a little bit provocative there. I just think it's a bit of a paradox to use that term, and I put asynchrony during SIMV.
Question back here.
The diaphragm is a fairly large muscle, and you're indirectly measuring electrical activity in one small area. Do you have any data that correlates the reliability of measuring the electrical activity in that one small area as representing the entire diaphragm?
So the original work that Krista and I did when we met in the lab in 1991 is exactly what you're talking about. It's validating the method to represent global diaphragm activation. So we have papers in animal studies where we've measured all over the place and correlated them together. But we also have paper in healthy subjects where we were able to show that just the crural diaphragm activity, which is what we're measuring with the catheter in this place, actually correlates to global diaphragm activation. And I think in 1998 there's also a paper that shows when we measured the diaphragm activity on the surface in very, very slim COPD patients, that when you ask them to perform a maximal inspiration, that the two signals are correlated.
Great, if no more questions, thank you very much.